Good afternoon, dear colleagues, my dear friends. Today we will continue our webinars, and today we will talk about drug safety in pregnancy, because it's a more sensitive part of drug safety, as I consider, because when you see teratogenic effects of drugs, you still understand sensitive period when these negative effects can realize it. And now these topics pay attention, not just me but and another organization, for example ICOP. And when you see the drug safety WHO organization, they pay attention on clinical diagnosis of adverse effects too. And when assume this point, I can say that it's another block, drug safety in special groups. We already, I hope, saw and listen in webinars, my lectures, paternal use of drugs, then teratogenic drugs, and today it will be third lecture of this block of lectures. For our new participants, I would like to introduce myself. My name is Galina Cordero. I am a medical doctor's MD master degree, QPPV, and head pharmacovigilance department, pharmacovigilance and clinical expert of DCK Pharmac with scientific background. Majority question considering epidemiology of negative effects in women, in pregnant women. And what say epidemiology? That approximately 80% of expectant mother take 3 or 4 drugs at some stage of pregnancy. Indication for drug use range from chronic illness such as epilepsy and depression to those commonly associated with pregnancy such as hypertension, GIT complaints, UTI complaints. From 2 to 3% of all live births are associated with congenital anomaly. Exogenous factors as a drug may account for only from 1 to 5% of these anomalies. More than 90% of pregnant women take prescribing or non-prescribing OTC medicines or use social drugs like tobacco and alcohol or illicit drugs at some time during pregnancy. In general, drugs should not be used during pregnancy unless absolutely necessary, as many can harm fetus. About 2–3% of all birth defects result from drugs they are taken to treat disorder of symptom. Most drugs with molecular weight less than 1,000 can cross placental barrier. Factors influences drug effect: environment, genetic, and time of exposure. Pregnancy induces maternal physiological changes, and you should know that its condition has some special which can be different from normal condition of women. It can be gastrointestinal absorption, hypertension, it's decrease in GI motility secondary to progesterone levels, decreased gastric acid secretion, increased gastric mucus secretion, and gastric emptying time. When we're talking about physiology changes like lung absorptions, cardiac and tidal volumes can be increased, by 50% and hyperventilation and increasing pulmonary blood flow. Transdermal absorption, increasing in peripheral vasodilatation, increasing in blood flow to skin, and increasing transdermal absorption. Organ system dynamic change during pregnancy take place too in category of pregnant women. It can be cardiovascular, blood volume increased by 30–50%, cardiac output increased by 30–50%, systemic vascular resistance decreased, and organ system dynamic change during pregnancy gynecologic. Uterine blood flow increased too. Organ system dynamic change during pregnancy. Kidney. Renal blood flow rate increased and glomerular filtration rate increased. Pharmacokinetics in pregnancy. First stage drug absorption have some changes too, and drug absorption in pregnant women has higher circulated levels of progesterone, slow the gastric emptying as well as gut motility, resulting in slower drug absorption. Parenteral drug administration is preferred in order to obtain a quick response. Drug compliance may be poor because of nausea and fear of adverse effect. Drug metabolism stage of pharmacokinetic in pregnant women include hepatic drug metabolized enzymes are induced during pregnancy, probably by higher concentration of circulated progesterone. This can lead to more rapid metabolic degradation, especially of highly lipid-soluble drugs. Drug excretion is a stage of pharmacokinetic in pregnancy. During pregnancy, the renal plasma flow increased by 100% and glomerular filtration rate by 70%. Hence, a drug which depend for the elimination mainly on kidney are eliminated more rapidly than in non-pregnant stage. Ampicillin, gentamicin, and cephalosporin. Maternal pharmacokinetic changes in pregnancy can have nausea and vomiting, as well as delayed gastric emptying may alter the absorption of drugs. Likewise, a pregnancy-induced increase in gastric pH may affect the absorption of weak acids and bases. High levels of estrogen and progesterone alter liver enzyme activity and increase elimination of some drugs, but result in accumulation of others. Increase total blood volume. There is increased total blood volume because of increase in fluid retention. This leads to change in cardiac output, blood pressure, and glomerular filtration rate. This result is change in volume of distribution of drug, change in metabolism, change in absorption, change in excretion of drug. Change in protein binding of drugs are passage of drugs through placenta. Normal physiologic changes that occur during pregnancy may alter medication effects, resulting in the need to monitor and sometimes adjust therapy. Maternal plasma volume, cardiac output, and glomerular filtration increase by 30–50%. As body fat increases during pregnancy and plasma albumin concentration decreases. Placental pharmacokinetics, physicochemical properties of drug, Lipid solubility. Lipophilic drugs tend to diffuse readily across placenta easily, whereas highly ionized drugs cross placenta slowly achieve very low in fetus if high enough maternal fetus concentration gradients are achieved. Polar compounds cross placenta in measurable amounts. Molecule size. Drugs with low molecular weight 500 Dalton cross placenta easily. Rate at which drug cross placenta. Amount of drug reaching fetus. Placental transporter. This transporter pumps drug from fetal blood back into maternal blood. Protein binding affects rate amount of transfer. A placental metabolism may convert toxic drugs to non-toxic metabolites. Blood flow through placenta increase during gestation. Compounds that alter blood flow alter maternal drug disposition. Placental transfer. Placental metabolism, dalkylation, hydroxylation, demethylation affects drug transfer across placenta. A term surface area of placenta is at its maximum. Nearly all substance can reach fetus. Fetal pharmacokinetics. Plasma binding proteins differ from maternal. Drugs transferred across placenta undergo first pass metabolism through fetal liver. Liver express metabolizing enzymes. Capacity is not fully developed and fetal kidneys is immature. Pharmacodynamics in pregnancy. Maternal drug action. Effects of drugs on reproductive tissue, breast, uterus may sometimes be altered. However, effects on other maternal tissues are not changed significantly by pregnancy. Therapeutic drug acts in fetus. Fetus may drug target steroids used to stimulate fetal lung maturation when preterm birth is expected. Predictable toxic drug action in fetus. Use ICIs, antihypertensive drugs. During pregnancy can cause irreversible renal damage in fetus due fetal hypertension. Its drugs angiotensin converting enzymes in pregnant women. Teratogenic drug action. Drug may interfere with passage of oxygen to or nutrients through placenta. Those have effects on most rapidly metabolized tissues, and it can be examples of thalidomide, vitamin A analogous, or folate deficiency. The issue, when you assume this knowledge, only half all pregnancies are planned. Many women need medication for pregnancy-induced conditions: morning sickness, chronic condition, epilepsy, incurrent condition, allergies, diabetes, hypertension, and women work with chemical exposure to radiation, use illicit drugs. Teratology, teratogenic drugs, it's part, and I hope you listening certain lectures which are related with this topic. In this lecture we will repeat, because repetition is matter of studiorum, branch of medical science devoted to the study of environment contribution of abnormal prenatal growth development. Term is derived from Greek teratos is monster. Teratogen, an agent or factor which can cause abnormalities of form, function, birth defects, is an exposed embryo fetus. Sixth principle of teratology was reflected in 1959, James Wilson. First, accessibility to teratogenesis depends on phenotype of conceptual manner in which interact with environment factor. Accessibility teratogen varies with development stage at time of exposure. Teratogenic agents act in specific ways on development cells, tissues to initiate abnormal developmental processes. First principles is access to adverse environmental influences to developing tissues depends on nature or influences. Final manifestation of altered development are death, malformation, growth retardation, and functional disorder. Manifestation of altered development increase in frequency in degree as dosage increasing no effect to 1000 lethality. Teratogen. To be considered teratogenic, a candidate substance or process should result in characteristic set of malformation, thalidomide, valproate problems, exert its effects at particular stage of fetal development, show dose-dependent incidence. Baseline teratogenic risk in pregnancy is about 30%. Teratogenesis. Defining the structure or functional dysgenesis of fetal organs. Typical manifestations include congenital malformation with varied severity, ultrauterine growth restriction, carcinogenesis, and fetal demise. You see periods, main embryonic periods, and main disorders which can happen with used teratogenic drugs, and you see that narrow tube defects from narrow tube defects to mental retardation, it's stage from 3rd week, and for 16 narrow tube defects and mental retardation. Afterwards, it can be disorders of central nervous system. When we see vascular disorders and others, it's from 3.5 weeks to 9 weeks, and it's going from 7 weeks to 8-9 weeks. It's heart disorders. Amelia meramelia starting from 4th week and to 9 weeks. It's divided in amelia meramelia from 3.5 to 5.56 weeks, and from this period starting disorder with upper limb. And you see same problems, amelia meramelia and lower limbs from 4th week to 8th week, 9 week lower limbs. Cleft lip and upper lip is from 5 weeks to 9 weeks. Low set malformance ears and deafness to disorders with development ears starting from 4th week to more than 16 weeks, 17 weeks, and microphthalmia, cataracts, glaucoma is from 1st weeks to 8 weeks, and disorder development from 8 weeks and to birth. Animal hypoplasia and staining and problem with teeth starting from 6 weeks and to birth. Cleft palate and problems disorder with development palate starting from 6 weeks to 16 weeks. Masculinization of female genitalia, external genitalia, from 7 weeks to birth. And when you assume this knowledge, you can say the first trimester pregnancy. In this trimester, different body organs of the fetus are forming. It is most critical time for teratogenesis. Dental prophylaxis with detailed instruction and a visual examination of the oral cavity without X-ray should be performed if the patient is pregnant. Elective dental treatment should be avoided in the morning, as women may feel nauseated in the morning. Second trimester is an excellent time for the patient to undergo dental prophylaxis if needed. The patient's periodontal status should be carefully evaluated during this period. And third trimester is the women begin to feel uncomfortable and it is difficult to her to lie in prone position for a long period of time. Drugs that may affect the newborn should not be given during this trimester. Position of patient or dental chair can cause hypotension due compression of gravid fetus on inferior vena cava, resulting in syncope. Stress can precipitate premature labor, and due to hormonal change in gingival tissue show exaggerated response to local irritant. Pre-embryotic stage, when we're talking about fetus, it's weeks from 0 to post-conception, period up to implantation, the fertilized ovum, all or nothing, avoid long half-life drugs, for example, when we're talking about isotretinoin. Effects of drugs on pregnancy. Pre-implantation stage blastocyst formation lasts for 16 days, show all or none effects, no teratogenesis. Period of organogenesis from 1756 days, drugs may produce no measurable effects, abortion, sublethal growth, anatomic defect, or permanent subtle metabolic or functional defect. Embryonic stage, weeks 3-8 post-conception period organization. Drugs in this period will have a great impact on body systems. Critical period, avoid or minimize all drug use in the first trimester whenever possible. Embryonic stage teratogens include angiotensin converting inhibitors, converting enzyme inhibitors, androgens, carbamazepine, carbimazole, cytotoxics, danazole, diethylstilbestrol, ethanol, lithium, misoprostol, penicillamine, phenytoin, tetracyclines, thalidomide, valproic acid, vitamin A and derivatives, for example, isotretinoin and warfarin. Fetal stage, weeks 9-38 post-conception, fetus continue to develop, grow and mature, remain susceptible to some drug effects. The central nervous system will be damaged by ethanol at any conceptional time. External genitalia may be virilized in female fetus by administration of danazole from 8 weeks onward. Angiotensin converter enzyme inhibitors, if given in the second and third trimester, can result in fetal renal dysfunction and subsequent oligohydramniones. Steroid inflammation drugs inhibit prostaglandin synthesis when given late in pregnancy may result in premature close of the fetal ductus arteriosus and fetal renal impairment. This group of drugs should therefore be avoided during the third trimester. Effect drugs on pregnancy from 2nd to 3rd trimester. Teratogenesis is unlikely, but drugs can cause retardation of physical or brain growth, behavioral defect, premature labor, neonatal toxicity, or even postnatal effect like cancer in later time. Labor delivery stage, danger of toxicity, and neonatal period. In this, you see that every stage can some special function we will talk about. Type of effect drugs in pregnancy. Teratogenicity, thalidomide detected as shortly after birth. Long-term latency, diethylstilbestrol increased risk of vaginal adenocarcinoma after puberty or abnormalities in testicle function, semen production. Predisposition to metabolic disease, Barker hypothesis, low birth weight, tobacco smoking associated with increased risk of diabetes, hypertension, heart disease in adulthood. Impaired intellectual social development, exposure to phenylbarbital alters programming of brain. And this group of teratogenesis can be very dangerous, and a drug effect of the fetus is determined larger by fetal age of exposure, drug potency, and drug dosage. Fetal age affects the type of drug effect. Before 20th day after fertilization, drugs given in this time typically have an all or nothing effect, killing the embryo or not affected it is at all. Teratogenesis like it during stage. During organogenesis between 20 and 56 days after fertilization, teratogenesis is most likely this stage. Drug reaching in embryo during this stage may result in spontaneous abortion, a sublutal growth, anatomic defect, true teratogenic effect, or cover term embryopathy, a permanent subtle metabolic or functional defects. They may manifest later in life, or the drugs may have not measurable effect. After organogenesis in the 2nd and 3rd trimester, teratogenesis is unlikely, but drugs may, after growth and function anomaly, form fetal organs and tissues. As placental metabolism increases, doses must be higher for fetal toxicity to occur. Teratogenic mechanism associated with medication use. Mechanism teratogenic with medication use. It can be folate antagonism, phenytoin, carbamazepine, valproic acid, and phenobarbital. Neural crest cell disruption, isotretinoin acetretin, endocrine disruption, oxidative stress, vascular disruption, tobacco smoking, and specific receptor or enzyme mediated of teratogenesis. It can be ketoconazole. When we're talking about malformation as a result of the teratogenic effects, its overall incidence of major congenital malformation is around from 2 to 3%. Minor malformation is around approximately 9%. 25% are due to genetic or chromosome abnormalities. 10% due to environmental causes, including drugs. 65% of unknown etiology. And according FDA, part played by drugs is probably small, less than 1%. Organogenesis, the theoretical time for drug-inducing congenital malformation, is usually the period of organogenesis, about 20-55 days after conception, about 34-69 days, 5-10 weeks after the first days of LMP. If a drug is given after the time, it will not produce a major anatomical defect, but more of functional one. General principle using drugs during pregnancy: it's avoid drugs if possible, avoid drugs in first trimester, choose drugs of proven safety at least toxicity, use short course and smallest doses. Chemical agent and drugs. Role of chemical agent drugs in production of anomaly is difficult to assess. Most studies are retrospective, relying on muscle memory. Large fraction of pharmaceutical drugs used by pregnant women. NIH study shows that 900 drugs taken by pregnant women, average of 4 women during pregnancy, only 20% of women using no drugs during pregnancy. Very few drug categories have been positively identified as being teratogenesis. When we continue topic Principes using drugs during pregnancy and lactation, first of all, evaluate the benefit-risk indicator, the ratio between danger or the risk of refusing treatment and the risk of adverse side effects, drug effects or complication in case of therapy. The risk of using the medicinal substance should not exceed the risk of not using it. Pharmacotherapy in the gestational period should be carried out only according to strict indication, preferably after 6 weeks, till up to 5 months of pregnancy. Consider the features of pharmacokinetics and pharmacodynamics medicinal substances, both in the body of the mother and the fetus. Exclude by the expectant mother so the pregnancy tobacco, alcohol, and caffeine intakes. Choose drugs with known metabolic pathways, proven efficiency and safety, at least toxic effect, tested by many years of practice using choline. Do not use drugs with embryotoxin and teratogenic drugs. Do not use drugs with embryotoxic teratogenic action. Use reducing courses of treatment and minimal therapeutic dose of selected drugs. Strive for monotherapy. If it necessary to use a combination of drugs due to run polypharmacy. If pharmacotherapy is ineffective, use an alternative effective treatment, for example surgery for teratogenesis. In process of drug treatment, carefully control, monitor the condition of mother and fetus, exclude self-treatment of pregnancy change. Drugs contraindicated during pregnancy. Drugs contraindicated during pregnancy. Some drugs in category X that are contraindicated to pregnancy and their effects the fetus are listed below. Vitamin A and its derivative, Accutane, isotretinoin, can cause birth defect. Thalidomide, seal-like limbs and other defects for camellia. Diacetylbestrol causes cancer of vagina or cervix in female children during the teenager years. Warfarin causes multiple birth defects. Danazol causes malformation in sex organs of female fetus. Simvastatin, avastatin, azostatin, cholesterol is needed for fetal growth and its reduction by statin cold harms the fetus. Finasteride, Pronor, finasteride is normally not prescribed to women. Pregnant females should not handle broken or crushing tablets since it can be absorbed, so the skin affects the sex organ. Testosterone can cause birth defects. Oral contraceptives can cause birth defects. Duphasтерide, urodont, affects the sex organ development of the fetus. Methotrexate causes cleft palate along with multiple defects. Aspirin. According aspirin and other drugs containing salicylate are not recommended during pregnancy, especially during the last 3 months. Acetylsalicylate, a common ingredient in many OTC painkillers, may make a pregnancy last longer and may cause severe bleeding before and after delivery. Nesteroid anti-inflammation drugs, failure of closure of ductus arteriosus, usually present in every fetus before birth. Infant after birth. Lithium salts, lithosan causes. Epstein anomaly is a rare heart problem that's present at birth. That means it's a congenital heart defect. In this condition, the valves that separate the top and bottom right heart chambers does not form correctly. This valve is called the tricuspid valve. As a result, the valve does not close as it should. Blood moves backward from the bottom to top chamber, making it harder for the heart to work. In people with Epstein anomaly, the heart can grow larger. The condition can lead to heart failure. Treatment of Epstein anomaly depends on the symptoms. Some people without symptoms only need regular health checkups. Others may need medicines and surgery. Folic acid deficiency causes neural tube defects, spina bifida, encephaly, encephalocele. Valproic acid epilim causes decreased absorption of folic acid and leads to deficiency of folic acid, which may result in neural tube defects in the fetus. Paroxetine oxide selective serotonin reuptake inhibitor causes cardiac defects. Medicinal product, chemical drugs, or abuse with proven embryo-fetal potential in humans. Embryo-fetal defects, as mentioned earlier, development disorders are not only manifested as structural malformation, as the embryo-fetal effects include spontaneous abortion, intrauterine growth retardation, embryo-fetal risk assessment, reversible functional postnatal effects such as sedation, hypoglycemia, bradycardia, and withdrawal effects. Central nervous system disorder from motility disturbance to learning disability, immunological infertility, and reproductive disorders. Most of these are not apparent at birth but will be manifested much later, which explain why the prevalence of development disorder is about 3% of births as about 8% or more at the age of 5 years. Medicinal products, chemicals, drugs of abuse with proven embryo-fetal potential in humans. Angiotensin converting enzymes inhibitors, angiotensin 2 receptor antagonists, indicated signs as anuria, alcohol, fetal alcohol syndrome effects, androgen masculinization, antimetabolized multiply malformation, benzodiazepines, floppy infant syndrome, carbamazepine, spina bifida multiply malformation, cocaine, central nervous system intestinal kidney damage, diethylstilbestrol, vaginal dysplasia and neoplasm, ionized radiation, microcephaly, leukemia, iodine overdose, reversible hypothyroidism, lead, cognitive development retardation, lithium, Epstein anomaly, methylmercury, cerebral palsy, mental retardation. Misoprostol, Mabus sequence reduction defects of extremities, penicillamine, cutis laxa, phenobarbital, primidone, anticonvulsive dose, multiply malformation, phenytoin, multiply malformation, polyhydrogenated biphenyls, metal retardation, neurological disorder, skin discoloration, retinoids, eros, central nervous system, cardiovascular and skeletal disorders, tetracycline after week 15, discoloration of teeth, thalidomide, malformation of extremities, autism, and phocomelia, trimethyl trimetadione, multiply malformation, valproic acid, vitamin A, 25 units per day, spina bifida, multiply malformation, retinoids. Drug prescribed during the pregnancy. FDA drug category used in pregnancy category A Adequate studies in human demonstrate no risk. Category B, animal studies indicate no risk, but there are no adequate studies in human. Animal studies show adverse effect, but adequate studies in human have no demonstrated risk. Category C, a potential risk when animal studies have been performed or animal studies indicated adverse effect and there are no data from human studies. These drugs may be used when potential benefits outweigh the potential risk. Category D, this evidence human fetal risk, but the potential benefit to mother may acceptable. And Category X, studies in animals of humans show adverse reaction reports or both have demonstration fetal abnormalities. This group contraindicated and the risk of using pregnant women clearly outweighed any possible benefit. Negative adverse effects of some drugs during pregnancy. Antibiotics, chloramphenicol, gray baby syndrome, peripheral vascular collapse, sulfonamides, kernicterus, metamoglobinemia, tetracyclines, dental discoloration, yellow and deformity, inhibition of bony growth, cataracts, aminoglycosides, fetal ototoxicity due to age, central nervous damage, antimalarials, intrauterine death, quinine, chloroquine, retinopathy, congenital death, deafness, corneal opacities if used at a dose higher than therapeutic. Antibiotics, penicillin, one of the safest antibiotics that could be used in pregnancy. Cephalosporin, one of the safest antibiotics in pregnancy. Macrolide, teramycin can be used too. Nitrofurantoin, commonly used in pregnancy to treat bacteria, should not be given to women later pregnancy due to potential risks of hemolytic anemia in the newborn. Metronidazole, not recommended for lactation. Vancomycin oral, possible fetal ototoxic effects. Category C, aminoglycoside, neomycin, tobramycin, quinolone, trimethoprim, chloramphenicol, quinolones, ciprofloxacin, levofloxacin. There are safety concerns of fluoroquinolone used during pregnancy and as a result are contraindicated except for women when no other safe alternative antibiotics exist. Triamterene can affect folate metabolism, so relatively contraindicated during pregnancy, especially the first semester. Chloramphenicol, gray baby syndrome can cause. Aminoglycoside, category D, tetracycline, aminoglycoside, streptomycin, gentamicin, streptomycin, entamycin, tetracycline, used during tooth development can cause permanent discoloration, enamel hypoplasia. Aminoglycoside, streptomycin, gentamicin, healing deficit, aids cranial nerve damage too. Antiviral, acyclovir B, recommended for treatment of varicella during pregnancy, especially during the second third trimester. Amantadine C, category CHD, teratology, folate, single ventricle with pulmonary atresia. Antiretroviral agents, category B, didanazine, etravarine, ritonavir, influviridine, and maravirac. Antiretroviral agent, category C, lamiviridine, delaviridine, indavir. Antifungal category, category B, amphotericin B, remains the drug of choice for systemic fungal infection in pregnancy despite its serious side effects, renal toxicity. Terbinafine, approved for the treatment in onychomycosis. Antifungals, ketoconazole inhibits placental microsomal aromatase cytochrome P450. Category CD, fluconazole, depends on dose, duration of dose, and category X, glyzofulvin, contraindicated during pregnancy. Pregnancy should be avoided first months after treatment. Cytotoxic drug methotrexate, potential teratogens that produce major congenital anomalies. Cyclophosphamide, chlorambucil, teratogenic, growth restriction, ear and facial abnormalities, absence of digits, and hypoplastic limbs. Azathioprine, category D, can cause birth defects. Cyclosporine, category C, does not appear to be major human teratogen, but could cause complications like preeclampsia, eclampsia, and oligohydramnios. Anti-inflammatory drugs and non-steroid anti-inflammatory drugs, aspirin in third trimester, ibuprofen, diclofenac, lexabib, category D, Moses retivix, could cause premature closure of ductus arteriosus. Anticonvulsant, phenytoin, adverse effects, fetal hydrantoin syndrome, microcephaly, cleft palate, hypoplastic changes, carbamazepine, spina bifida, phenobarbital, relatively safe, sodium valproate, neural tube defect, NTD, hypospadias, microstomia, developmental delay. Fetal hydrantoin syndrome, what this means? Phenytoin-induced fetal hydrantoin syndrome. Fetal hydrantoin syndrome, also called fetal dilantin syndrome, is a group of defects caused to the development fetus by exposure to the teratogenic effects of phenytoin or carbamazepine. Hormonal agents, corticosteroid, growth retardation as an adverse effect, cleft palate and lip. D-ethylstilbestrol uses as morning after pill, vaginal adenosine in female offspring of teenager, risk of testicle cancer in later life in male offspring too. Antithyroid drugs, neonatal hypothyroidism and goitre, clomiphene, NTD, multiply gestation Down syndrome can be, synthetic progestins, masculinization in female fetus, hypospadias in male. Psychiatric drugs is substance of abuse, lithium Epstein anomaly can cause as an adverse effect, lysergic acid diethylamide, fracture chromosomes anomaly in fetus stunted growth. Alcohol can cause fetal alcohol syndrome, prenatal onset growth deficiency, developmental delay, facial dysmorphia, short palpebral fissures, ptosis, strabismus, ear abnormality, long filtrum viscous in upper lip, thin upper lip, multiply joint anomaly and cardiac defects, and mental abnormality, ADHD, and cardiac defect, ISD more than VSD. Heroin, irritability, hyperactivity, tremors. Cocaine, abruptio, placenta, preferred labor, cerebral infarction. Beta blockers, fetal bradycardia. Vitamin K, large dose, hyperbilinemia, hemolysis, and kernicterus. When we're talking about anticoagulants, Decumarol, intrauterine day, severe bleeding in neonate, warfarin, birth defects, abortion, hypoplasia of nasal bones, stippled epiphyseal calcification resembling chondrodysplasia punctata, central nervous system abnormality, and drugs is used in second and third trimester. Aspirin, hemorrhagic disease of newborns. And some of other drugs, cytotoxic drug, multiply fetal malformation and abortion, isotretinoin, central nervous defects, facial palsy, deafness, cardiac defects, acute embryopathy, oxygen in higher concentration, retrolental fibroplasia and blindness, thalidomide, phocomelia, cardiac malformation, was historically used as a sedative. Thiazide diuretic, neonatal thrombocytopenia, angiotensin conversion enzyme inhibitor, renal tubular dysgenesia, lung hypoplasia, anuria, and oligohydramnios, misoprostol, prostaglandin, Mobius syndrome, vitamin D, Williams syndrome, infantile hypercalcemia, supravalvular aortic stenosis, and and alpha fatties. Cardiovascular drugs, we talked about contraindicated is angiotensin converter inhibitors and RBC, contraindicated in pregnancy, food drug administration, pregnancy category C for the first trimester of pregnancy and D during the second and third trimester. Prenatal exposure of an angiotensin converter inhibitor is enalapril or to an angiotensin 2 receptor antagonist losartan during the second or third trimester of pregnancy, associated with increased risk for fetal hypertension, renal failure, oligohydramnios leading to fetal growth restriction, joint contractures, pulmonary hypoplasia, stillbirth, neonatal death. Beta blockers of the pregnancy category C can cause fetal bradycardia, hypoglycemia, and possibly fetal growth restriction. Amiodarone food drug administration pregnancy category D should only be given during pregnancy when there are no alternatives and benefit outweigh risk. Calcium channel blockers, when given during the first trimester, possibly phalangeal deformities. When given during the second or third trimester, fetal growth restriction is food drug pregnancy category C, and methyldopa food drug administration pregnancy category B. Thiazide diuretics can cause neonatal hyponatremia, hypokalemia, and thrombocytopenia, food drug pregnancy category D. Statins, food drug administration pregnancy category X. Statins should be avoided during pregnancy. Congenital anomalies have been reported. Insulin and hypoglycemic drugs. Insulin is the treatment of choice for diabetes during pregnancy. Neonates born from mothers with diabetes who are taking oral hypoglycemics in pregnancy may have hypoglycemia. Metformin in FDA pregnancy category B. Progesterone, danazole synthetic progestin, but not the low doses. Use it in oral contraceptive times when given during the first 14 weeks. Masculinization of female fetus genitals. FDA pregnancy category X. Progestin exposure is associated with an increased prevalence of cardiovascular abnormalities. Combined oral contraceptive pills when taken during the early stage of an unrecognized pregnancy are believed to be teratogenic agents. Amyloid drugs, carbimazole, propyltyrosine, both drugs cross the placenta and may cause fetal hypothyroidism in higher doses, and propyltyrosine is preferred for new cases as there is less transfer across the placenta. Corticosteroids, when used in the first trimester, possible orophyseal clefts, food drugs pregnancy category. Hydrocortisone and prednisolone are largely more than 90% metabolized by placental dehydrogenase, but fluorinated corticosteroid, betamethasone and dexamethasone are not, thus making them the drugs of choice when treated the fetus in the aim of therapy, such as for fetal lung maturation. GI drugs, it's blockade like omeprazole blockade, proton pumps. Omeprazole does not seem to be teratogenic, but less is known about the PPIs during pregnancy. Ranitidine crosses the placenta. Also, the manufacturer advised you should be avoid during pregnancy. Epidemiology study reveals no increased prevalence of other fatal outcomes. Rather, teratogenesis studies are reassuring. Metoclopramide has been assigned to pregnancy category B by the FDA. Dermatologic agents based in large population-based follow study. Topical corticosteroids are generally considered safe for use in any stage of pregnancy. Benzodiazepines Food drug pregnancy category D. If benzodiazepines, especially those long half-life, are taken in late pregnancy, they can cause neonatal respiratory depression, poor temperature regulation, poor feeding, and hypotonicity. There is a risk of neonatal withdrawal symptom and craniofacial anomalies. Avoid regular use only if there is clear indication such as seizure control. Food drug pregnancy category D, neonatal lethargy, hypotonia, poor feeding, hypothyroidism, goiter, and nephrogenic diabetes insipidus. Increased risk of Epstein's anomaly when it used in early pregnancy. CCRI drugs, fluoxetine category D, is the CCRI with the lowest known risk in pregnancy, paroxetine in category D. CCRI shall not be used during pregnancy unless the potential benefit outweighed the risk. There is a small increased risk of congenital heart defects when CCRIs are taken during the early pregnancy. If the CCRIs are used during the third trimester, there is a risk of neonatal withdrawal symptoms and persistent pulmonary hypertension in the newborn has been reported. Opioids, codeine, meroperidine, morphine, food drug pregnancy category C. If neonates of women addicted to opioid, withdrawal symptoms possibly occurring 6 to 8 days after birth. With higher doses given the hour before delivery, possibly neonatal central nervous system depression, bradycardia, tricyclic antidepressant. Tricyclic antidepressant, amitriptyline, imipramine, nortriptyline, have low known risk than other newer antidepressants. Respiratory drugs, there are not convincing evidence in any of the drugs commonly used to that respiratory disorder cause particular problems during pregnancy. Pseudoephedrine, possible risk of atherosclerosis. Food drug pregnancy category is category C. Loratadine, possible risk of hypospadias. Food drug pregnancy category B. Killed virus, toxoid, or recombinant vaccines may be given during pregnancy. And it will be another lectures related with vaccination, problem with vaccination, immunization, and prescribing immunoglobulins for pregnant women. Live attenuated vaccines, varicella, measles, mumps, polio, and rubella should be given 3 months before pregnancy or postpartum. Live virus vaccines are contraindicated in pregnancy secondary to the potential risk of fetal infection. Smoking. It's bad habits, and carbon monoxide and nicotine in cigarettes cause hypoxia and vasoconstriction, increasing risk of spontaneous abortion, fetal growth restriction, abruption of placenta premature rupture of the membranes, preterm birth, chorea amniotic is stillbirth. Neonates whose mothers smoke are also more likely to have anencephalia, congenital heart defects, raphaceal clefts, sudden infant death syndrome, deficiency in physical growth and intelligence, and behavioral problems. Smoking during pregnancy is linking to childhood asthma too. Alcohol increases the risk of spontaneous abortion, decreases birth weight about 1 kilogram to 1.3 kilogram if regular drinking. Binge drinking in particular can cause fetal alcohol syndrome. This syndrome may include fetal growth restriction, fatal and cardiovascular defects, neurological dysfunction, vision and hearing problems, behavioral and intellectual disabilities, and can cause neonatal death due to failure of thrive FTT syndrome. Fetal alcohol syndrome, FIS syndrome, is pattern of mental and physical defects and cause developing fetus in association with the high level for alcohol consumption during pregnancy. Alcohol crosses the placenta barrier and can stunt fetal growth of weight, create differential facial stigmata, damage neurons and brain structures, which can result in physiological and behavioral problems and cause other physical damage. Drugs used in a perinatal period, oxytocin used to induction of labor, can be cause of adverse effects like hyperbilirubinemia in girl babies, prolonging cortisone, adrenal increase in infant, nonsteroid anti-inflammation drugs, premature close of the ductal arteries, dexamethasone, paraventricular lactation. Drug prescribing during pregnancy. Drugs may be prescribed for treatment of common minor ailments, a trauma pre-existing or pregnancy-aggravated medical illness. Treatment of common minor ailments and analgesics and antipyretics, paracetamol category B, safe and normal recommended doses. Noise of vomiting, meclizine, cyclizine category B is safe, and tocopramide category B uses in labor during anesthesia, aldosterone category B/C, and antidiarrheal medication loperamide category B. Heartburn, dyspepsia, non-absorbent antacids like aluminum hydroxide category B, if taken in early pregnancy, it increased risk of congenital malformation. Sucralfan category B, H2 blockers category B are safe. All PPIs category B except omeprazole category C. Lansoprazole safest PPI in pregnancy. Constipation, bulk laxatives category B containing bran isabhula or methylcellulose are best to simple constipation. Common cold, antihistaminic, non-sedating, loratadine, phenoxidine, cetirizine, sedat, and sedatina, chlorpheniramine, and diphenylhydramine, category B. Oral decongestant, pseudoephedrine, category B, risk of astrocytosis. Loratadine, possible risk of hypospadias D. Cough, expectorants, guaifenesin, category C. Antitussives, codeine, and category C, and dextromethorphan, category C. Bronchial asthma, short-acting beta-symptomatic terbutaline, category B, salbutamol, category C. Long-acting beta-symptomatic salmeterol, category C. Inhaled steroid budesonide, category B. Beclomethasone, dipropionate, category C. Increase in preeclampsia in asthmatic women on oral steroids. Nedocramil, category B, inhaled anti-inflammatory agents with no systemic side effects. When we're talking about hypertension in pregnancy, it's of alone major times 2. Chronic hypertension, blood pressure more than 140 on 90 mm HD is diagnosed before pregnancy in first 20 weeks of gestation or persists 42 days after delivery. Gestational hypertension, blood pressure more or equal 149 mm HD established after 20 weeks of gestation are not associated with proteinuria, preeclampsia, eclampsia, hypertension, proteinuria more than 0.3 grams on 24 hours, and edema after 23 weeks of gestation. Eclampsia is defined as appearance of generalized convulsion associated with signs of preeclampsia of the occurrence with 7 days of parturition and not caused by epilepsy or other convulsive disorder. Central nervous system disease, hypertension can include metal dopa and first-line drug, adverse event include drowsiness, depression, pastoral hypertension. Beta blockers like atenolol, cibutolol, labetalol should not be preferred within first 28 weeks. Fetal bradycardia can happen as adverse event, hypoglycemia, possibly fetal growth restriction. Hypertensive imaging is hydralazine, category C 5 10 milligrams, or labetalol 20 milligrams, and you remember the angiotensin converting inhibitors, or RBC category D, is contraindicated in pregnant women. Calcium blocker blockers when given during first trimester, possibly phalangeal deformities when given during second third trimester, fetal growth restriction. When we're talking about diuretics, it's furosemide category C, thiazides category D, is spironolactone category B. Statins category X should be avoided during pregnancy. Congenital abnormalities have been reported. Cardiac arrhythmias, digoxin category C, maternal atrial flutter or fibrillation. Quinidine, relatively safe during late pregnancy for supraventricular tachycardia, some ventricular arrhythmia. Amiodarone category D should only be given during pregnancy when there are not alternatives, benefit or outweigh risk. As we're talking about amiodarone. Anticoagulants. Heparin is drugs of choice. When you're talking about pre-existing aggravated medical illness, used to management of venous thromboembolism in pregnancy, they do not cross placenta. Food drug pregnancy category low molecular weight heparin category B, and ultrafractionated heparin is category C. Warfarin category XD, women with mechanical heart valves who are at higher risk of thromboembolism, and thrombolytic agents teratogenesis category C, urokinase category B, TPA category C, relatively contraindicated. Epilepsy. Women with epilepsy are at higher risk of having fetal malformation even without exposure to anticonvulsant medication. Phenobarbital category D, phenytoin category D, carbamazepam may be used. Also, it does have some side effects, always as birth defects. Valproate category D is contraindicated during pregnancy. All epileptic pregnant women must receive folic acid, not less 5 mg per day, so-called pregnancy to reduce risk of birth defect, because this group of drug, you remember, can cause folate deficiency. Fetal valproate syndrome is potential embryopathies and can occur as a result from maternal intake of valproic acid, sodium valproate during pregnancy. The use of valproic acid monotherapy in the first trimester of pregnancy was associated with significantly increased risk of major and minor malformation, including a 20-fold increase in neural tube defects, cleft lip and palate, cardiovascular abnormalities, genitourinary defects, developmental delay, endocrinological disorder, limb defects, and autism, comparing the risk without the use of antiepileptic drugs. You see how many disorders can cause valproate, and it's now assumed as fetal valproate syndrome. You can find it in literature as FEVR syndrome, fetal valproate syndrome. Treatment pre-existing pregnancy, diabetes mellitus, and thyroid disorders. Diet restrictions on therapy should be initiated if needed. Metformin category B. Oral hypoglycemia cause fetal hyperinsulinemia, so it's not used. It also increased malformation if taken in early pregnancy. In early pregnancy, it's we're talking oral hypoglycemics. And for teratogenesis, for propionate is preferred to carbimazole due to its greater protein binding capacity. Also, propionate associated liver failure and pregnancy may favor the use of metimazole. Stable iodine and radioactive iodine category X. Drug of choice: pregnancy with aggravated illness, hypertension, alpha-metyl-dopa, hypertension, labetalol, hypertension, ephedrine, diabetes mellitus, it's insulin, hypothyroidism, L-thyroxine, hyperthyroidism, first trimester, it's propionate, second trimester, carbimazole and metimazole, Caesar's and eclampsia, magnesium sulfate. Prophylaxis of malaria, chloroquinone, and you remember that Pulperum vilvex malaria, first trimester chloroquinone, second chloroquinone. Falciparum malaria, first trimester is quinine, and second trimester artesunate, sulfadoxine, pyrimethamine. Several complicated malarias, first trimester parenteral quinine plus oral quinine plus indomethacin, second trimester parental artemisinin derivate followed by oral ICT. Induction of labor, oxytocin, gonococcal infection, streptomycin, toxoplasmosis, spiramycin, asthma, acute attack in pregnancy, albuterol, acute attack in labor, ipratropium, and syphilis, penicillin G. General care of pregnant women morning sickness can include pyridoxine, non-pharmacogenic aids like azathioprine, avoid products with a high sodium content, acid preparation contain alginate advisable, H2 antagonists are not licensed. Headache and backache, paracetamol safe to use so pregnancy, codeine, dihydrogen co-formulated with paracetamol can be used, may cause depression, respiration, newborn babies if taken near team. Term and aspirin, ibuprofen is avoided. Constipation, increased fluids in the fiber and diet, bulk form and laxative and lactose could be tried. Doxosate safe, Sana not teratol, but used in later stage may cause uterine contraction. Hemorrhoids cream is ointment, bismuth oxide, ice pack, prevention recurrence of constipation. Candidiasis thrush, vaginal candidiasis is 2 times more frequent, imidazole, antifungal effect but not licensed. Varicose vein edema and muscle cramps, 10-20 pregnant women, up to 80 suffer with leg edema and also experience cramps in calf muscles in late pregnancy, resting with their legs elevated, calcium and kalium reduced leg cramps. Pruritus after 20% of pregnant women, oily calamine lotion. Stretch marks, hyperpigmentation, exercise after pregnancy, tretinoin. Cough and colds, avoid products containing systemic symptomatic decongestants. Treat the chronic disorder more frequently in bronchial asthma, epilepsy, hypertension, tuberculosis, diabetes mellitus, and depression, urinary tract infection, vulvovaginitis, respiratory tract infection, influenza, and drug compatibility during pregnancy and lactation. Hydroxychloroquine, allowed pregnancy, yes. Allowed during lactation, yes. Azathioprine, allowed in pregnancy, yes. And allowed during lactation, yes. Neflorivimab, glucocorticoids, prednisone, yes. Allowed during lactation, yes. Fluorinated glucorticoid, dexamethasone and betamethasone, yes, should be limited to situations where fetal treatment is required. It's a low pregnancy. And low enduring lactation, yes. Cyclosporine, yes. Low enduring, yes. Tacrolimus, yes, yes. Intravenous immunoglobulin, lower in pregnancy, yes. Lactation, less. Methotrexate, no. Stop 3 months before conception. And low during lactation, no. Mica phenolate fetal, no. Stop at least 6 weeks before conception and not available data. In lactation, cyclophosphamide, no. Stop at least 3 months before conception and lower during lactation, no available data. Belimumab, no. Insufficient data on plan and exposure in the first trimester is low risk, and during lactation, no available data. Rituximab, no insufficient data on plan and exposure in the first trimester is first low risk, not available data. And during lactation, and angiotensin-converting enzyme inhibitors, no. When pregnancy is confirmed, and yes, limited data low during lactation. The process of assessing reproductive embryo phytotoxic effect of drugs, the process of reproductive embryo phytotoxic drugs includes the establishment of biological plausibility and epidemiology evidence with the following criteria. Sudden increase the prevalence of specific malformation observed as an associated establishment between the introduction or an increased usage of a drug and increased incidence of a specific malformation at certain region and during the given time. Drug use must have taken place in sensitive period for induction of that specific malformation. It must be established that the drug are not conditions for which the drug is prescribed causes the specific malformation. The drug of its metabolized suspected of causing the malformation has to be proven capable of reaching the embryo or fetus. The findings have to be confirmed by another independent study. The result of specific laboratory animal studies must support the epidemiology finding. It's in reproductive epidemiology, this principle of causal analytical studies of birth defect is simple. Compare with observed number of exposure pregnancies with an adverse outcome with the expected number. However, this implies that the rate adverse outcomes pregnancies in the population and the rate of exposure might be unknown. The easiest possible techniques to study pregnancy prospectively. This demands larger number of products producing many problems such as mistakes in data entry and dealing with confounders, the covariables with exposure and the outcome, and the known as the uncertainment rate. The second term of causal analytical studies and cohort approach is the historical or prospective, when the adverse reproductive outcome is studied in a group of women defined by specific exposure situation. The outcome in the exposed group is compared either with the total population or with an unexposed control cohort. The absorbed number of adverse outcomes is compared with expected number under the assumption that exposure does not affect outcome. Such cohort studies make it possible to examine many different outcomes after specific exposure, spontaneous abortion, low birth weight, perinatal mortality, and different types of malformation. The big problem with cohort studies is often define the cohort and identifying a sufficient number of women who have been exposed to the factor under study. Both types of analytical studies can be combined in a more powerful methodology can control study within cohort. These epidemiological studies lead to identification of a possible statistical association between the outcome and exposure. Elaborates clear examples of the meaning of such association and, among others, emphasizes the importance of not forgetting random variation as an explanation of the association. The latter is especially important when handling cluster space-time aggregated occurrence of adverse reproductive outcomes, often loosely suggested to be caused by environment, agent, and medicinal product. How a prescription medication labeling for pregnancy and lactation. When you're talking about labeling SMPC, it's different chapters, and it's 8.1 pregnancy registry. You can find a summary clinical consideration data, 8.2 chapter lactation, there is summary clinical consideration data, and female and male reproductive fat potential, pregnancy tasting, contraception, infertility. In this, it's United States labeling. You can find the information in these chapters of these chapters of SMPC. Before a new prescription medication is approved by the Food Drug Administration United States, product labeling must be developed. A prescription product labeling is a detailed document that must include information about the approved to use the drug. You can find these chapters, and section 8, using specific population, has subsection for pregnancy, lactation, reproductive potential. The pregnancy 8.1, lactation 8.2 subsection includes 3 hidden summary, clinical consideration, and data. Please, my dear friends, my dear colleagues, pay attention on these chapters. If you live, for example, in the United States, if you live in European Union use EMA labeling. In the European Union, the summary product characteristics, SMPC, is the key reference documents on a media product and the basis for information how to use the medicinal product, safety and effectively. The SMPC is the result of agreed positions in the medicinal product and defined during the assessment process before after marketing authorization. It contributes in informing factors that may influence the benefit and the risk. The SMPC is updated throughout the life of the products as new data are collected, is available to healthcare professional, patient and consumers organizations. The content, the audits, the SMPC are defined by Article 11, Directive 2000/83/EC, and you can use this information to reading label information for drug products. You can find on these links. It's FDA, it's summary product characteristic of European Union, a committee, medicinal products for human guide on risk assessment of medicinal products on human reproduction and lactation from data to labeling. Please use these links in your daily practice. Next lectures, it will be drug safety in breastfeeding. Welcome to these lectures, and I will be very thankful if you will find ability to subscribe on my channels, to leave comments under these lectures. Please subscribe on my channels. It will help to get this useful and considered information for medical doctors, healthcare professional, for medical advisors, pharmaceutical industry specialists, pharmacovigilance specialists. It will increase safety of drugs. It will decrease frequency of medical errors too. My dear colleagues, thank you very much for your attention. I will be waiting for my future lectures. Have a nice day. Bye bye.